So Dr. Anne Holland is a professor of physiotherapy at Monash University and Alfred Health in Melbourne, Australia. Her research focuses on clinical trials of known drug treatments for people with respiratory disease and implementation of research into practice. She has published over 270 papers in peer-reviewed journals, and her research is cited in 18 clinical guidelines. Anne is currently the chair of the Pulmonary Rehabilitation Assembly for the American Thoracic Society. So we are pleased to have Dr. Anne Holland here to present about home-based and remote exercise testing in chronic lung disease. Welcome, Anne. Thanks for waking up so early to participate in the symposium today. And please go ahead.
Thank you for inviting me, and good afternoon, everybody. Is my slides visible on the screen to everybody now?
Yep. Yes.
Okay, great. So today I've been asked to present the results of a recent rapid review that we conducted, which was really around trying to work out what best practice might be during the COVID-19 pandemic. And we're really interested in this issue of what types of exercise testing were able to be done at home and remotely in people with chronic lung disease. I have no disclosures related to this presentation. So as you've already heard today, during the pandemic, many pulmonary rehab programs have transitioned very rapidly to remote delivery models. And we do have some clinical trials already conducted before the COVID era, which show that remote rehabilitation is certainly feasible and it's safe and it seems to have beneficial effects. But one of the things about these programs is that they have all included an in-person exercise test at a centre prior to commencing the program. And that fulfills a number of functions. One is, of course, to assess the outcomes at the end, but also to assess the safety of exercise, to look at things like desaturation and heart rate and blood pressure responses and symptoms, and also to enable accurate exercise prescription to get the intensity right so that the program is effective. So during the pandemic, centre-based or in-person assessment of exercise capacity has frequently not been possible, and certainly for us here in Australia for a long time there was no in-person exercise testing being conducted, although there's a very limited return in some centres now. So what we became aware of was that some pulmonary rehab programs had commenced exercise testing at home, and in general they were conducting tests with minimal space requirements, so things like a sit-to-stand test or a step test. And sometimes that included remote monitoring of things like saturation and heart rate, but sometimes it didn't. And sometimes it was video monitored and sometimes it was not. Sometimes it was being done independently. But we're also aware that some programs were not conducting any exercise testing prior to commencing patients on home pulmonary rehab. And for new patients commencing the program who hadn't previously attended the centre or who weren't known to the program, this was quite challenging because the therapists had very little idea of their responses to exercise, particularly whether they desaturated, and the safety and also the intensity. So the questions that we had for this particular review were, firstly, which functional exercise tests have been conducted in the home setting in people with chronic lung disease, and which of those have been conducted remotely? So they were the two primary questions. We then wanted to know, for those tests that had been conducted in the home or remotely, what were their clinometric properties? So what did we know about their feasibility, reliability, validity and responsiveness to rehab? And we also wanted to know whether those functional exercise tests could be used to assess safety and prescribe exercise intensity, either as an in-person test in the home environment or remotely. So given the circumstances and the urgency, we decided to do this as a rapid review rather than a systematic review. So in our group, often a systematic review will take us somewhere between 6 months and a year to do. And I think this one took us about 3 weeks. So we really did it quite quickly compared to normal. But that meant that we changed the method somewhat. So it meant that we had just one reviewer for article selection and data extraction. And we didn't do things like a formal risk of bias assessment. And we had quite a large team, so we had about 12 people who contributed to the review who were here in our group in Melbourne. We included studies that reported conducting an exercise test at home or remotely in people with chronic respiratory disease, or that reported the clinometric properties of those tests. So the clinometric properties could be in the home environment, or they may not have been. We just included them anyway, those studies, regardless of whether they were conducted at home, because we wanted to know about things like reliability, even if it wasn't in the home environment. We included people with a range of chronic lung diseases, and the main outcome was a number of reports of home or remote administration for each test. And then for those tests, we went on to look at their clinometric properties, so their feasibility, reliability, validity, and responsiveness to rehab. We also noted down which patient variables had been monitored during the test, so particularly saturation, but also heart rate, symptoms, and blood pressure, and documented any methods that had been used to prescribe exercise training intensity on the basis of that test. And the protocol was registered, so you can have a look at it on Prospero if that's of interest. So this is the Prisma diagram about how we selected the studies, and the important bits from this slide are just really that we found almost 4,000 articles in the first search, and after we had screened those for eligibility, we came down to a total of 84 studies in 85 different reports. So there was a fair number of studies included. So these are the primary outcomes for the number of tests, reports of home administration, remote administration of the tests. And you can see that there's not a huge amount of this. So in terms of home administration, so this is in-person administration at home, there's just 1 or 2 studies for a range of these tests. So 6-minute walk test, 2 studies, some of the sit to stand tests, so 5 times sit to stand, 10 times sit to stand, and the 1 minute sit to stand. For the step test, the 6-minute stepper test has been used at home. So this is a test where you use a hydraulic stepper, so it uses equipment rather than just an independent step, and the timed up and go. In terms of remote administration, so this is where the assessor is located somewhere different but supervises the test. We found just the 6-minute walk test and the 3-minute step test. So for the 6-minute walk test, that had been conducted using apps. I know there are a number of apps out there on the App Store that you will be able to find if you have a look. This used 2 different apps actually, but one of them up there is the MoveSense, which is an open source coding system which enables you to build your own app. So that one is certainly freely available. And for the 3-minute step test, that was done using video conferencing. So the supervision was remote and the person did their own monitoring with a pulse oximeter on site, which was visible on the screen. So we had just a few studies which allowed us to assess the difference between administering a test in the centre and at home. A number of those were for the 6-minute walk test, and as you can see, one of them is from our group there. So we did a comparison of centre versus home a few years ago because we were interested in this issue of home rehab and how you assess people. And what we found was that on average, the 6-minute walk distance was 30 metres longer at the centre than it was at home. And that was primarily because the track length at home was a lot shorter. So most of these tests were conducted inside the person's house, but not all. And on average, the track length was somewhere around 12 metres shorter or more than it would have been if it was conducted in the centre where we had a 30-metre track. There was a study conducted by Dana Brooks, though, a few years previous to that, which looked at indoor versus outdoor 6-minute walk test. And actually, there was no difference in the length there. So if you conducted a test on a sidewalk in a flat environment, obviously had to have reasonable weather. Actually, there was no discernible difference between those tests at all. So an outdoor 6-minute walk test appears to be feasible. In terms of the apps, we could see that the absolute error for the walking distance was quite small, somewhere between sort of 4 and 5%. So that appeared to be a reasonable amount of error for the distance. With the 3-minute step test, what we saw when we looked at that was it was really about measurement of physiological variables and other outcomes of that test. So we saw very little difference between remote and in-person supervision, and none of that would be clinically significant. So I'm now going to talk about the clinometric properties of each of the tests, starting with the 6-minute walk test. So this is one that I think we know a lot about the clinometric properties already, and it's been extensively surveyed in the literature. So we didn't go back and do that again, but we did look at what we knew in relation to how it had been conducted at home and remotely. So what we found for feasibility was that track length was often too short at home and we couldn't get the recommended track length. However, the reliability was excellent, and we know that it's excellent at home as well as in the centre. The validity at home may be poor because the distance is not comparable to what we see when we measure it in the centre. So it wouldn't be reasonable to measure a 6-minute walk distance at home and then enter it into somebody's medical record in terms of allowing a comparison between those distances. It does, of course, have good responsiveness to pulmonary rehab. We've known that for a long time. It allows a good assessment of desaturation, and there is an equation validated for exercise prescription. So it is possible to prescribe an exercise intensity off the basis of a 6-minute walk test. The sit-to-stand test, one of the things that made this body of literature quite tricky is that there were 6 different variants of the sit-to-stand test that had been described in the literature. And as I showed you, 3 of those had been used at home, which is the 5 and 10 times sit-to-stand in the 1 minute. In terms of feasibility, there was some limited data about that, which suggests that 6 to 15% can't complete a test. And that's really generally due to orthopedic problems or balance problems, which make it difficult to stand from a chair. For those who can complete the test, the reliability is excellent. The test has good validity, and interestingly, that's similar across all the sit-to-stand variants. So we tend to think, I think, of the sort of the 1 minute, 30-second sit-to-stand as being more reflective of endurance, and the 5 and 10 times sit-to-stand being more reflective of strength, or quad strength particularly. But we couldn't see any evidence of that when we systematically looked at the literature. They all had very good correlations with quad strength and with other measures of exercise capacity. There was some evidence of good responsiveness to pulmonary rehab for the 5 times sit-to-stand and the 30-second and 1 minute sit-to-stand. The physiological responses to exercise are not always measured during this test. So sometimes people measured things like saturation and heart rate, but not always. When they did measure those things, there was less desaturation than 6-minute walk test. And I'm going to show you the data for that in just a minute. And we couldn't find any evidence that this had been used for exercise prescription. So here's the desaturation data, and I've presented this just for the 1 minute sit-to-stand because that's really where the bulk of the data lie. So you can see here it's been used across a number of different groups, some of whom you would expect to desaturate with exercise. And the important data here are just under the 1 minute sit-to-stand column in the middle and in the 6-minute walk test column here. And these data are the lowest saturation on exercise or the decrease in saturation. And the message really to take home is just that the saturation for the 6-minute walk test, the lowest saturation is always lower. Sometimes that difference is small, like you see up the top here. Sometimes that difference is larger, as you see down the bottom, but it's always in the same direction. So there's always more desaturation on a walk test than there is on a 1 minute sit-to-stand when we look at the same patients. So moving on now to step tests. Well, this body of literature is even messier than the sit-to-stand. So there are 5 different variants and they're all quite different. So some of them use a fixed cadence with a metronome, so you step at the same rate all the way through. Some of them are incremental, so a bit like a shuttle walk test in that the rate of stepping gets harder and more rapid as you go through the test. Some of them you can step at any cadence that you like. And there's one variant which has been actually published quite a lot, which is the hydraulic stepper, which is the 6-minute stepper test. So the feasibility for these tests is, I think, quite variable but poorly reported. So with the step tests, I think you would expect that there would be some people who could not do this test because of musculoskeletal limitations and balance problems, but that's not really been systematically reported in the literature. However, the tests do have excellent reliability and they appear to have good validity in terms of their correlation with other important measures. Their responsiveness to pulmonary rehab appears to be variable. Sometimes it's very good and sometimes it's pretty limited. So I think that may reflect the difference in these tests because they're probably measuring slightly different things across the different types of step tests. Again, they appear to have less desaturation than the 6-minute walk test, but this is not as great as what we saw with the sit-to-stand test, about 2 to 3% less. There is one set of equations for exercise prescription from the 6-minute stepper test, but they have been unvalidated. So we don't have, I think, robust ways to prescribe exercise at this point from these tests as well, although I know that there are groups around the world who are working on that, particularly for the incremental varieties of this test. One thing I just mentioned about the hydraulic stepper test is that although the data suggested that there was quite good reliability, there was also some suggestion that it was a device that warmed up over time because of the hydraulics warming up. So that means that a practice test was always necessary with that, really to warm up the equipment rather than to warm up the participant. So the timed up and go, the good thing about this test was that it did seem to be performed fairly consistently. There was only really one version of this, people did it the same way. For feasibility, we found that 3 to 13% may be unable to complete, so similar to a sit-to-stand test, not surprisingly, given that it has similar components. The reliability was excellent and there was good validity. One of the differences for this test is it's been used to distinguish fallers from non-fallers, particularly in COPD, similar to how it has in other older people, and that's not something that had really been looked at in the other tests. Might be relevant for home. Again, it had variable responsiveness to pulmonary rehabilitation. Physiological responses for this test are very rarely monitored, so it's not something that people do in order to measure saturation or heart rate responses. And as far as we could see, it had not been used for exercise prescription. So in conclusion, what we can say is that there are some tests that have been performed at home in people with chronic lung disease with in-person supervision, and the ones that seem to be feasible are the sit to stand, the step, and the timed up and go. It also looks like remote supervision may be possible in selected patients, although there are few data available about that and variable methods. So certainly, apps seem feasible for things like walk tests, but not a lot of data. And remote supervision using video conferencing also seems to be possible for some types of tests. And I'm aware of some of that in clinical practice at the moment as well, particularly for the sit to stand test. It seems like the sit to stand, step and timed up and go are quite useful to quantify the outcomes of home-based pulmonary rehabilitation. They should be able to show change over time in most people by the looks of things. They certainly don't seem to reveal the full extent of desaturation on walking. That may or may not be important depending on the degree of desaturation, but I think it's something often we like to know before we start people on a program, and particularly if we're starting people on a program at home or remotely. At the moment, we don't have validated methods to prescribe exercise intensity on the basis of those tests. And I think what this tells us is that we've got some tests that we can use, probably useful as outcome measures, but at the moment we don't have a substitute for that in-person exercise test at the centre, which gives us that whole package of information. So I think we need to think about who those patients might be who are the priority for in-centre exercise testing when that becomes available and when it can become performed safely for patients. So thank you for listening, and I'm happy to take some questions.
Thank you so much, Anne, for your great presentation. Very interesting to see that there is so little in the literature about remote testing, so more on home-based testing. So we have some questions. One question here from Sunita. What feasibility issues are there for moving this test to remote monitoring? Can you see some of them?
Yeah, look, I think there are a few challenges which may not be insurmountable, but they are challenges. So one would be around the monitoring. So certainly in Australia, it's not common that the patients that we would see in pulmonary rehab would have a pulse oximeter at home. So that's not necessarily available to them. So for many patients, they would require that to be transported to their house and would need to be able to use it. I think if we want to do a visualised test with video conferencing, what we found in our current remote pulmonary rehab is that the video conferencing type model suits some patients but not others. Some find it easy to use and some find it very difficult to use. And obviously with an exercise test, you need to be able to visualise the person accurately. And I think there is a potential safety issue as well. So, you're not there to be standing beside the person who's standing up and sitting down on a chair. So there is potentially an issue around that. So, some of these issues are able to be addressed in some patients, but I think that there will always be a group of patients in whom it's very difficult to conduct a test remotely.
Mm-hmm. Actually, we have a question about adverse events, if any of these studies reported about adverse events. And I think there's only one study, the one that described the 3-minute step test via video conferencing. Did they report anything about safety or adverse events?
Yeah, they did. Actually, that was done by our group as well, by Narelle Cox, who works here in Melbourne. So we did look at that. That was a study that was done in people with CF. So it tended to be a younger group, adults, but a younger group than many of the other patients that we see. And there were no adverse events in that group.
Okay. So